Welcome this morning to the Coronavirus Market webinar. My name is Bob McIlvaine, and I'm your host this morning. We're going to try to do this without having to mute everybody. We may ask you if it gets too noisy to self-mute and then come back in as necessary, but we do want to be very collegial here, so we'd prefer not to have arbitrary muting of everybody. It's a kind of a momentous moment, or I'm repeating myself there. It's momentous that so much is happening right now, and just reading the headlines this morning and the dire predictions for the United States and for New York and other places, and I think I visualized New York back in about 1600 and Manhattan Island today, and think in terms of the world at that same period of time and the world today. And as Anthony Fauci was saying last night, there's probably going to be a surge of coronavirus in the southern hemisphere. And with all those people traveling to the northern hemisphere, we're going to have a continuation of this problem for a long while. So there is we think, a big potential for a proactive program using filters, mass destruction devices, and instrumentation, along with safety protocols to allow businesses to function with a number of infections not much greater than sheltering in place. And this morning you got the Wall Street Journal supporting Trump's initiative to get back to work sooner rather than later, but to take whatever precautions are necessary. And I think this is a huge opportunity for the industry that we serve here. We believe that room, vehicle, and building air purification systems can be upgraded to provide some of this safety. Contrary to some of the government officials who want to discourage people from using masks because of their shortage, there's a pretty good evidence that masks make a huge difference in the welfare of the wearers. And it's not a coincidence that China only had 3,000 deaths, but everybody's required to wear masks. So we project the need for 3 billion masks per day. China's gone from 20 million to 200 million. And we do have one of the Chinese mask producers on the call this morning. There's also a big need to expand the production of N95 masks, which are only a million per day. And no matter what is done, we're not going to get nearly the masks that are required in the time that's required. So we've been talking to companies like Ecolab, who makes H2O2 sanitizing systems that Battelle has tested on masks. So we have been heavily involved in evaluating life quality as well as the economic impact of the disease in each country of the world. So there are numerous projections as to the number of deaths which will be caused by COVID-19. But there's general agreement that if no action is taken, as many as 100 million Americans could become ill and that 1% would die. And so simplistically, we just said, this is a no plan. Everybody goes back to work after Easter. Most of the states start functioning the way Texas and some of these others have that have little control. And we could have this million deaths or so that would probably would peak by month 4 or 5 and then kind of level out and drop off, but probably not completely, because you do have this world travel activity that we were talking about here. One alternative is the social distancing and sheltering in place, and the number of lives that would probably be lost under that scenario would be about 150,000 lives. Whereas a proactive back to work program with investment in protective gear procedures could result in 165,000 deaths, or 15,000 deaths more than the distancing scenario. So one of the potential benefits for the return to work after Easter would be an increase in economic output. However, if during the year there are 1 million deaths, there's likely to be a big negative impact on the economy, not considering the impact on life quality, which will be huge. We were fortunate enough to do a study for the largest, one of the largest healthcare providers in the world, with sales over $100 billion. And one of the outcomes of that was the life quality assessment of about 58 million for every life that's lost. So if a million lives were lost, you're talking about a life quality cost of $58 trillion. So that from the standpoint of trade-off here of the no plan back to work with no consideration of loss of life, the life quality comparison is stark. So the no plan, by the time you can add the economic and the life quality impacts, the no plan is by far the least attractive, and the proactive plan gives you some of the social benefits, life quality benefits. It does have more actual deaths, but less total impact on life quality. And so we think that there's a very strong case to be made for the proactive policies here. And one of the things that, well, I think I'll get that into it in a minute here. But so social distancing has both the economic and social consequences. The average person chooses a life of 80 years, which includes pleasure rather than an austere life of 100 years. So this is part of our study, that there's actually a 25% premium that can be used to calculate the social cost of distancing and sheltering in place. So basically, since you're willing to give up 20% of your life to be able to have a beer now and then, eat ice cream, and drive a car, that if sheltering in place is the equivalent of an austere life, then that's a huge penalty that society is paying. So it calculated at 25% for sheltering in place. So 300 million Americans would generate a negative 75 million life years of life quality by sheltering in place for a year. And this compares to but this is a trade-off that we are actually making now, because we, rather than shelter in place, we are content with 15 to 40,000 deaths from the flu each year. So that, with that being said, I'd like to then go into the economics here. But before I do that, are there questions that people would like to raise before we get into the next aspect of this? Okay, let's go to the slideshow here. So this is a cost-benefit analysis. We've been fortunate in that we've been helping suppliers analyze filters, cleanroom apparel, treatment chemicals, masks, instrumentation, and other products for at least 4 decades here. And some of our clients have funded studies on the total cost of ownership with the goal of providing the best products. In the 1980s, 2 of the world's largest instrument companies developed systems to measure multiple pollutants and make decisions based on the aggregate contamination. And they asked us to do some work for them, and we developed a common metric so that you could determine whether decreasing NOx while increasing CO was beneficial or not. And so we had some experience in this, and then again, we had one of the largest healthcare companies came to us, and they wanted to evaluate reusable versus single-use gowns. And so the result was a metric which takes into account comfort, life quality aspects, but also into tribal values and future value discounts. And this metric is ideal for the coronavirus decision making and has been published in hospital magazines. So McIlvaine is working with suppliers to help them determine which products can be best applied to cost effectively mitigate coronavirus. This is being done on an accelerated basis, similar to what we did after the BP oil spill to determine the best dissolved oxygen analyzer to use in the underwater drones to track the spill magnitude. And obviously that was a high accelerated process with a number of webinars and things that we pursued with BP and NASA and so forth. So all the proactive solutions to mitigate the coronavirus can be evaluated based on a common metric to measure all harm and good. This takes into account the discomfort of wearing masks, shows social distancing, and other initiatives. So for instance, you can use far UV and possibly kill the viruses and protect people now, but will that give you cancer 50 years from now? And you've got to therefore discount future values to compare those. So the benefits have to be based on life quality of individuals. The medical community uses quality adjusted life years. A decision of who gets the ventilator depends on the expected remaining life of the patients. So a young prison inmate serving a life sentence and on a suicide watch would get the ventilator, while an older, happy member of society would not. There's a better metric, which is called quality enhanced life days. The cost in dollars can be converted into life quality benefits depending on how funds are distributed. Even things like a direct payment to all citizens versus a tax reduction for the wealthy result in different quality enhanced life day results. All costs and benefits have to be adjusted based on tribal values, my country or the world, and future discount, raise debt now and pay later. One economist estimates the economic impact at $10 million per minute, but the social cost is also significant. Social distancing alone has a negative impact on life quality for billions of people around the world. So the decision to choose a particular technology has to be based on the economic and social impact. A simple analysis considers only the cost versus the number of infections eliminated. Using this narrow definition, there is no cost to social distancing. The medical community and the environmental protection agencies use a life value which is often pegged at $10 million per death. This would justify an investment of $10 million per minute, or $5.3 trillion a year, to save 526,000 people per year. Let's assume that these people would live 50 more years, so this investment pays off to the tune of 26.3 million life years. In terms of social distancing, it is necessary to determine for each individual the ratio of life quality with and without the social distancing. So an individual might be willing to trade 1.1 years with social distancing for 1 year without it. If this involves 5 billion people, then it would total 500 million life years, or 20 million life years for 2 weeks. The problem with this type of analysis, however, is that it's not a question of social distancing or life as usual. It's social distancing versus business not as usual, but business with the fear and concern of the virus. So it may be the trade-off may be a lot less than 10%. It might be only 2 or 3%. These are not abstract ratios. They are the way we all live our lives. Instead of living to 100 and never being in a car or a social gathering, or never eat sweets, drink liquor, or so forth, we choose to do these things and only live to be 80. So we have attached a life quality bonus of 25% to live our more reckless lifestyles. So the willingness to trade 1.1 years with social distancing for 1 year without has already been demonstrated. The CDC estimates that between 12,000 and 61,000 deaths annually since 2010 were caused by the flu. Globally, World Health Organization estimates that the flu kills 290,000 to 650,000 people per year. I might also add that the vaccines that have been created are only about 30 to 40% effective. And there will be a vaccine created for the coronavirus. But again, if it's only 40% effective, we're looking at coronavirus being here for the long term. The coronavirus is potentially far worse than the typical flu. The Spanish flu in 1918 killed 50 million people. The Black Death killed as many as 200 million people, which at similar percentages would be over 1 billion people today. And again, we have this reoccurrence potential. Even with the vaccine, HIV is still killing people after decades. At best, a vaccine is 18 months away from widespread use. So we've got a program, if we're going to be proactive, that is going to be in high gear for at least 18 months, and maybe in a lower gear, but should be continuous for the foreseeable future. So investments such as HEPA-filtered HVAC systems are long-term investments. And such investments can take into account the potential for new pandemics in addition to this one. And I think that is going to be the psychology. We now realize that they are going to happen, and it's just a matter of time and when. So we have gone through this social distancing comparison here, and I won't get into all the details, but in the initial comparison, we didn't take into account this contact fear. But listening to some of the social analysts here, it's very likely that if everybody goes back to work, there's going to be continuing problems. And one of our family members just found that out. He runs a number of plants that are considered to be essential. So the workers do come to work every day. But in one of the plants, somebody tested positive, and the next day nobody showed up at the plant. So the idea that we have a happy group of people going to work, ignoring the fact that a few people get sick and die, is probably not a realistic scenario. So this comparison really of the distancing, where we consider, for instance, that the cost of social distancing is higher than the swine flu, that may still be the case, but maybe it's a much closer. And obviously, if there is a proactive way for us to even eliminate flu generally, there is a major social and economic benefit to it. I'm not going to go into some of the calculations of the costs, medical costs, but medical care alone for a coronavirus patient can exceed $1 million. Here was just an analysis of MERS and just the cost for a critically ill patient that had to have renal replacement therapy, and it ran over $700,000. So the one way to calculate it, because EPA has got this $10 million for a death, and but that is only there are at least 10 others that are infected with serious infections and hospitalized, and we didn't even include the other 90 people that would get it but not be hospitalized. And there's a family life quality impact of an additional $1 million for the 50 people who would be associated with the 10 people who are hospitalized. And so you get a quality impact per death of $30 million. But when you think of some of the other aspects of it, you actually realize that it's could be as much as 3 times the the narrow look of the life quality for the one individual. So that we basically then have an impact that's much larger. So what can be done to minimize that impact? Here are just some of the examples. The isolation room certainly is a way to do that, but it's a long-term investment, and so you've got to look at it in terms of justifying it for a long period of time. I mentioned the far UV disinfection, which is interesting because people would be exposed to some UV. The far UV, they say, is not that detrimental to health, but there might be some potential long-range cancer impacts, so you'd have to weigh the one versus the other. You've got ozone disinfection in the space. Obviously, the medical masks have a negative comfort aspect. The N95 masks have even more comfort aspects. We've got the room air purifiers, which are inexpensive, but there's a question of the effectiveness. We've got HVAC upgrades. We've got foot sanitizers. Obviously, social distancing is a way to do it. And then you get country to country distancing, which is also being practiced now. So wearing of gowns is another positive step. And the average hospital spends very little on the gowning procedures and disposal compared to a pharmaceutical clean room. The sanitizing chemicals, but you need to avoid the dangers. UV robots, UV room purifiers, even got hospital beauty. Many clean room experts walk into a hospital and say, this is a repository for germs and doesn't look anything like a sterile environment should look like. Filter media efficiency is another big variable. And then things like portable operating suites and other portable devices. So here were just some attempts to show the costs of some of these things in terms of how many lives would have to be saved. And for an isolation room that might cost $4 million, you would have to save 0.4 patients per year under a more modest evaluation protocol, but only 3 out of 0.003 patients per year with a more robust analysis of the harm. And the foot sanitizers are much lower than that. The HVAC upgrade is relatively expensive. You might have to for a huge one for a large hospital, you might have to save a couple lives a year. But as we're going to have a speaker here in a minute, would show you that those kind of costs are being incurred now anyway. And improved gowning would also have some cost benefit, where if elaborate gowning were used in a hospital and you could only save even less than one life per year, it would be justifiable. And then the room air purifiers, you're looking at a situation where obviously an isolation room in a hospital is one thing, but a room purifier for someone in an apartment building somewhere is another question, and probably harder to justify. So we ran through a couple of these things where just in a random apartment, what the odds are that the room purifier would pick up the virus, what are the odds that the person would get the virus in any case, and it's pretty hard to justify the room purifier just for a random apartment building. But if the owner is in an apartment building where there is a self-isolated tenant, the odds might increase to 1 in 100 that the room purifier would provide the necessary protection. Also, the odds of contracting the disease may have increased to 1 in 100 with an infected tenant in the building. This brings the lives saved to only 1 in 10,000 here, and so you've got easy justification of a room air purifier by an owner. So the N95 masks and the surgical masks, we ran through some numbers there as to what kind of justification there would be for large uses of masks, and the conclusion would be there don't need to be that many lives saved in order to do that. So we believe that the innovation can be very lucrative, and there are certainly ways that probably masks can be made more palatable. Students walk around with hoodies and so forth, like shouldn't they be wearing masks? And it is interesting talking to the Chinese. They're kind of surprised that there's a negative impact feeling about them here in the United States. And in fact, it's a symbol in some places of the world that's positive rather than the negative, and it is required in at least 2 provinces of China. Anybody who walks out in public has to have them. So there are a lot of more specific things as well, that you've got employees that travel on public transportation that would use HEPA filtered air, sort of wearing masks during travel and throughout the workday as appropriate, and plants that adopt clean room technology. So these are all innovations that would improve life quality and would reduce the risk and not be tremendously costly. So the hospitals are challenged with who gets ventilators, who doesn't. When should a ventilator be removed and needed, if needed, by another patient? And they are confronted by clean room experts decrying hospital art draperies and these other things. So there are a lot of life quality decisions that have to be made. So hospitals have elaborate programs to decide on priorities of care. And a selection based on quality adjusted life years is common, but many also consider the contribution which will be made by the individual if he recovers. So hospital boards which wrestle with the various rating methods, uh, such as this present shortage of ventilators. The difficulty in the decision making and why you have a whole board of people at a lot of these hospitals is the assumption that noocracy or government by the wise is more applicable than direct democracy. Again, if the choice of a new heart is between a young prison inmate on a suicide watch and a happy, productive, older individual, the noocrats may choose the inmate based on quality or quality adjusted life years. But the two individuals would likely both agree that the older person should have the heart. The democratic approach is actually fairly unambiguous. Again, we were talking about most people place a 25% premium on unhealthy activities such as ice cream and driving cars. So all this can be worked out in terms of life quality on the basis of what people actually want and how they conduct their lives. And we don't have to have a noocratic approach to it, which once you get into that, you get into a quagmire. And we've been looking at sustainability systems that a lot of the corporations have, and they become extremely complicated because they are taking on all sorts of philosophic aspects when the simple answer is what would the aggregation of the people want. And we came up with all this independently, but I was pleased just in the last couple of days to see that a Nobel Prize winner had a similar concept to that, and it's just reappeared because of all this. So the total social and economic impact that I talked about before is closer to 56 billion when you talk of terms of the loss of life quality for months of on the people who are not deceased, and so you have a very powerful impact. And so we're looking at possibly 100 to 150,000 deaths in the United States here, just based on the Italian experience. And what this particular article says is that this curve is pretty well established in most if the same amount of protection occurs here in the U.S. as occurred in Italy, we're going to have a curve similar to them. About 25,000 people are going to die in Italy. You're seeing that they're going to be at 1,000 deaths a day for these are 4-day periods. So they're going to have more than 1,000 deaths a day for a period there of 10 or 15 days. So you're getting huge amounts of deaths, and this will end up with about 25,000 deaths. And we're on that same curve here in the United States, and we would be ending up with 150,000 deaths. So, but we do believe that PM measurement would be a critical tool, and I'm kind of jumping around now to some of the proactive things that we'll be doing. And so ambient air averages 500,000 particles per cubic foot, and it can be reduced. Obviously, in a class 1 clean room, it's down to 1 particles, 0.3 microns and larger. But many spaces, like a food processing plant, would try to get down to the 100,000 particles. So it can be roughly assumed that the system, say a room purifier in an apartment building, reducing the particulate count by 80% would be informative. And So what I'd like to do here is, because I know Bob Burkhead is on the phone with us here, and he's developed, he's done an extensive amount of work on measuring the performance of HVAC filters, very well known in the industry. And Bob, would you like to comment on your thoughts on this?
Certainly, Bob. Thank you. I just let everybody know that we've done quite a bit of assessment of all manner of these products that Bob's talked about so far. And in a lot of years of doing this, it's always concerned me that we never really measured the performance of these devices and techniques at the breathing level, at a person's exposure point. So a few years ago, we started doing a variation of a test protocol that's many of you may know, the room air cleaner test method, the AHAM protocol in the US. It's different in China and Europe. We do that test, and we also do all the typical single pass testing of air filter performance. Those are all good tools to make decisions, but they still don't allow you to assess what happens at that breathing level, at a person's exposure point. So we mixed them. We brought them together. The AHAM room protocol, you may know, is just a preset room. The prescribed dosing is required, and then you just measure what happens in the room. And that's fine for measuring the performance of a room air cleaner, but it still doesn't do the job of assessing what happens to a person. So we just simply added the test duct that's used for MERV type testing for HVAC style products. And then instead of monitoring performance in the duct in a single pass, we monitor performance in the room near a prescribed breathing zone. And that many of our customers have taken to that as a way of evaluating technologies that can't be evaluated any other way. A lot of the new technologies just simply don't work in single pass measurement. So they do work, and demonstrably so, in a room. Many of these products work, and they just can't be shown to work, and that's why we developed it. But I explained all that to Bob at a trade show a few weeks ago, and he got all excited about it. And the point is that there is a technique that we could use to assess performance as it impacts a person sitting in a room or standing or being active in a room. And rather than limiting our thinking to single pass testing that we've used to sell filters for decades, and room exposure tests like the AHAM protocol for room air cleaners that we've also used for decades. So what's the critical aspect here is that you could measure anything you wanted to measure in that room. We could put every instrument we own in there and measure ozone and VOCs and small particles, big particles, all the exposure levels that are important. And this is also more important, we could all measure the performance of sensors, which are a key element in this loop of controlling the indoor air quality exposures. Sensors are, high quality or low quality, just like filters. So this is a tool to measure the sensor capabilities as well. We think it's an invaluable evaluation tool, but it really needs to leapfrog to the in situ testing that Bob's been talking about, and that has not been done. There's no reason to think it couldn't work in the field, but what you measure and how you measure it becomes very, very dicey. And as you may know, in situ applications are tough to quantify correctly. That step has not been taken. This would have to happen, as I've described it to you, would have to happen in the laboratory. And I still think that's going to be an extremely valuable tool in assessing whether anything can be believed when you hear the claims. Again, we had prepared to present this all. We've done quite a bit of work at the World Filtration Congress, which was scheduled in April in San Diego. and that has been canceled or at least postponed. So publicly, we haven't shown it yet, but we will as soon as there's an opportunity. And I believe it to be a strong tool. Any lab could do it. It's not unique to us. It's a simple and effective way to measure indoor air quality.
No, that's good, Bob. In fact, why don't we actually do a what we call an interweb view, similar to what we did with Charlie, who's going to be doing talking in a minute or two here, and capture what at least some of what you would have said there in San Diego. And let's do that sooner rather than later. But before we go on there, we've got the Lighthouse people. I think some of the Lighthouse people are on with us there, and they're a major supplier of this instrumentation for measuring air quality in rooms, and wondered if they had any comments or thoughts on this. I guess specifically whether taking the high-tech, expensive systems that you use in a clean room and tailoring them for an environment that probably is not going to be able to afford the same quality level. And even if if we don't get any feedback from them now, we certainly can get that or ask them for it in the future here. I think we'll now go on to Charlie's. I want to get in the show here and get out of this, and we're then going to go on to actually a summary of the recorded presentation that Charlie Rodriguez and Robin Collins made a couple days ago. It's I think a 40-minute long YouTube presentation, and all of you have links to it. But we'd now like to ask Charlie and Robin to give us a summary here, and particularly with this important new information that you have on the coronavirus.
Yeah, so thank you, Bob. The company that Robin and I represent is a company called Pathogen Solutions. We're based out of the St. Petersburg, Florida area. If you can go to the next slide, I'll go through this as quickly as possible. So I really don't, so I can keep everybody's attention. First of all, if you see right there, if you want to expand that out, I don't know if you can expand that out a little bit, but that's a picture of our foot sanitation station. As you can see, it has UV light on the front and back. It's really a simple process for our foot sanitation station. It's a plug and play. So essentially what you do is you plug it into the wall anywhere. What it does is protect your perimeter. We use it in different fields. Initially, before coronavirus, our company was concentrating on medical fields, so hospitals, clean room spaces, compound pharmacies. Now, this is with this virus, it's the fields have expanded. There are a lot of companies, a lot of facilities, manufacturing, food processing. They're all looking to see how they can keep these pathogens and these viruses and bacteria outside of what their storerooms of their storeroom. So if you can go to the next slide, if you can click it one more time, what you do is you step on this, and then the light goes on. And the light goes on. We use a technology that includes ozone plus UV light. It's the only type of device in its market. I'm sorry, go ahead. Yeah, go ahead. Right there.
Yeah, I think that I think with the PDF somehow the sequence is not working. So
that's okay. That's okay. Yeah. I'll keep going. So what our foot sanitation station, as you can see that young lady right there, she stepped on it. It's at it. What we do is we secure perimeters. So we're placing stations at entrances. It's a main component of our team's planning. We're placing them in hospitals. We're placing them at the entrance of facilities. We're placing them at the entrances of ante rooms and clean rooms. So there's different locations. It just depends on where you are looking to keep your environment sterile. Next slide, please. as you can see here, this is before the potential microlobe this aspersion of pathogens in any type of facility. So if you go to the next slide. Oh, one more back. Sorry. There should be one more.
It's actually the same slide. You might be able to push the down arrow and see if the animation works.
Okay. Unfortunately,
Probably not.
yeah,
That's
I should have
okay.
sent you the PowerPoint.
yeah,
That's okay.
No worries.
So what it does is, as you can see, if you can see in this picture, you place it at different points. What the actual slide does, and what it does is it reduces the microbial load throughout the facility to where there's barely any pathogens, and there'll be locations with zero to little pathogens throughout your facility. Next slide.
Before we even go on to the next slide, I just, visualizing the fact that people that are walking along and say the one, the person transmitting the viruses walks in an area and then someone else walks near it, or there's an airflow of one reason or another, it's going to get picked up, and in that portion of it, which is finer aerosols, can actually be then deposited on surfaces all over the building. Is that a fair assessment of how it probably spread so fast?
Yes, and there's an article that came out yesterday talking about the importance of leaving your shoes outside, even in your homes now. People that are traveling to different supermarkets, different locations to pick up the needed supplies that they need. So yes, there is the possibility of viruses like the coronavirus and any other type of pathogen that might be entering into your homes, especially if you have young kids, to leave your shoes outside.
Yeah, I just want, so we want gone to the next slide. Yep. Here. Yeah.
As you can see there, these are some of the cost-effective locations for use: clean rooms, pharmaceutical manufacturing, changing rooms, food processing. These are some of the newer markets that we have entered. Our product has been around, introduced last year. Again, we've concentrated solely on healthcare for the most part, but now with everything changing, I mean, the atmosphere is changing on a daily basis. So these are the things that we're focusing on now. This is what I focus on more.
Yeah, that's certainly a big opportunity with all these applications, I would think.
Yes.
Yeah. In addition to these applications, there are cruise ships, hotels, airports, as well as healthcare, hospitals, senior living communities like nursing homes.
Yeah.
Next slide. So we just did a recent study, and it was released last Friday, that our foot sanitizing station, the Pathogen Solutions footwear sanitizing station, killed 100% of the coronavirus 22E, the EPA recommended surrogate standard for testing the efficacy of all products used to combat COVID-19 in a matter of 8 seconds. So essentially, to break that down, if you were to go, God forbid, to any location that had it, you stepped on it, and you were bringing the coronavirus in. If you were to step on this device for the 8 seconds, which is the recommended time that I always recommend any of my customers, you won't have coronavirus on the bottom of your foot. I'll let you guys read the top, but it was tested in Canada, and we got the results back last week. Next slide. So what's important? The facts. Footwear spreads the following pathogens to surface. We know that when hospitals incur a lot of HAIs due to viruses, bacteria, fungi, mold causing HAIs in their hospital, our footwear sanitizing station kills 100% of the coronavirus and up to 99.999% of other deadly infection-causing pathogens. So we talk about, I know there's people on this call right now that talk that might have the sticky pads, they have the shoe covers, robots, antimicrobial pads, things like that do work. I think they're great. You're doing the right thing. This is something that would be used in combination with those type of sticky pads. I'm going to let Robin talk a little bit about the shoe covers and UV robots.
Thank you very much, Charlie. Yeah, I mean, acquiring PPE right now is extremely difficult. It was a big focus in Bob's discussion earlier. Of course, face masks and face shields are what's most critical, but shoe covers are also very important. This unit can be used in place of shoe covers. It can also be used to clean shoe covers. And then with regards to the UV robots, the reality is they're effective, but they're limited in availability, and they take a long time to use, and they require additional staff. This, you just plug it in and go.
Yeah, that shoe cover cleaning is an interesting addition. I hadn't thought of that one before. That's very interesting. Yeah.
We can move to the next slide. Thanks, Bob. So there was this study done, it appeared in Infection Control and Hospital Epidemiology in 2016. The primary authors were Drs. Koganti and Donsky. Donsky's a world-renowned infectious disease physician. What they did was they put a non-pathogenic viral marker on the floor of 10 patients' room and monitored the spread of the virus over 3 days. This was the results the first day, showing 100% of what was on the floor ended up on the footwear, and it literally spread all over the room, on the patient's hands, visitor's chair. What's interesting is, additionally, it also spread to adjacent rooms, the nursing station, and portable equipment. So it's just one of many studies showing that what's on floors and what's on footwear spreads.
You know, in regard to that, we've been involved in some clean room studies which showed actually that the clean room rating, you know, from class 1 to class 100,000 was as much dependent on the movement in the room as it was on the amount of HVAC air that was put through the room. So it would be nominally rated at 100 feet per minute as a class 100 room. But in actuality, if there's nobody in it, it's probably a class 1 room. And if there are a lot of people moving around, it could be a class 10,000 room. And so I think this supports your point, is that these viruses are being propelled by a lot of the movement in the room. So once they get on the floor of the room, they're going to move around just as you said they did here.
Absolutely.
So we currently
Charlie, do you want to take it from here?
Yes, we currently work with Advent Health in Connerton here. As you can see, their director of pharmacies, Jeffrey Miley, referenced us, and we've added the Pathogen Solutions footwear sanitation stations, both our clean and anti rooms, to help reduce the risk of pathogens contaminating our clean room. We've updated protocol to require each employee who enters our clean room to use the sanitation station. Since implementation, our last air and surface samples were negative for any growth in our room. So it's amazing that it's both air and surface. And we currently look forward to continuing the use of our Pathogen Solutions footwear sanitizing stations to minimize the risk for our patients and provide the safest care possible.
Charlie, I just want to add that this entire study done at Advent Health Connerton will be published in Croffel's updated white paper addressing the 5 cores of HAI prevention and patient satisfaction. Quickly, the results for the Advent Health Connerton study: it was the first hospital in the U.S. to implement it. It's an LTAC, so they have very sick patients, ventilator dependent. They installed 9 units. The infection rate dropped 34% from February to August. And this was especially impressive because during construction, infection rates often go up. It actually went down. Additionally, the employees loved it, not only for when they come into work and while they're working, but before they go home. What's great, no slip and falls related to the unit in over a year, and the units can be built into the floor or placed onto the floor. And then, as Charlie mentioned, the pharmacy air and surfaces samples were negative for any pathogen growth.
Yeah, that's certainly very impressive, and I think underscores the potential of this whole proactive program when something can be this cost effective. I mean, obviously, we're talking huge benefits here.
Thank you. We agree. Do you want to take this one, Charlie, or would you like for me to?
Go ahead, Robin. Go ahead.
Okay, well, I think we all know that pathogens can survive on surfaces. Looking at this chart at the top, C. difficile, 5 months, going down to staph or MRSA, 7 days to 7 months, SARS coronavirus, 72 hours to 28 days, and COVID-19, we're hearing different reports. One report from the CDC said that they were able to find RNA of COVID-19 on a cruise ship out 17 days.
Yeah, I think they're finding it in hospital ductwork in China that that it's been there for a while too. So I'm sure we'll get more support.
What happens during construction is oftentimes vibration will result in having what's in the ductwork fall out into the air and have it circulated that way.
That's another good point. Yeah.
Charlie?
Excuse me. So as you can see, we have some NFS study results. The pathogen rejection in a matter of 10 seconds. You can see that there's a significant increase in log reduction at the 10-second intervals for different types of these deadly pathogens that are in clean room spaces, that are in food manufacturing spaces, they're in hospital spaces. Next slide. Again, these are log reduction up to 99.9% in different intervals. We do 6, 8, and 10. We got E. coli, MRSA, C. diff, and we don't have the coronavirus one here up here, but we know that at 8-second intervals, it does kill at 100%. Next slide. Our technology is different. We know that there's UV robots out there. What we use is a combination of ozone and UVC. So what the ozone does is create holes in the cell wall, and what the UVC is denatures the cell at a DNA level. So at that point, it's killing 99.99% of the deadliest superbugs in seconds. Again, our technology, when you're using floor disinfectants, you got pictures of before, after, and within 2 hours. We know that the floor disinfectant alters the DNA, and pathogens may regenerate. The UVC lights alters the DNA. Again, pathogens may regenerate. Using our product, which is the only kind anywhere, it limits regeneration and denatures the DNA. So as you can see there, that it really limits any kind of infection afterwards. And that's it. I appreciate your time. Thank you, Bob, for having us on here, and we'll continue to listen to everybody else. Thank you, Robin.
My pleasure. Does anyone have any questions about the technology?
Yeah, we will be giving the email addresses to everybody. So the very, very, very interesting work. And I think, the fact that what you're offering here, and you even mentioned it, is really complementary to a lot of the other technologies, underscores what we'd like to say next here, which is that one of the functions that we believe that we can perform is to what we call silo busting, which is breaking down these silos between, even in some of the companies that you're looking at here, even between their own divisions, but certainly between products. So there's no reason that some of the information about where you should, that would be useful to Robin and Charlie here is not also going to be useful to many others. And in fact, with a proactive process and program, the more complementary technologies that can be used together to reduce the costs and increase the performance, the better. So we will be, sending you the contact names here from the people who participated this morning. And then we do encourage the further communications, and we do think also this is one of the activities that we can perform is to help some of you work together, and particularly as we get around the world. We're working very closely in India right now, and some of you are very active in India. Others have no contacts at all there, and so I think all these things are going to be opportunities for collaboration. And I'm going to just quickly go through a few other things here relative to the masks. There is the potential for the reuse of these masks. And here's a BioQuell analysis that was done by Battelle, which basically shows that they can be reused. So I think this is an important potential, and we're going to be pursuing this as well. And the calculations that we have here are just huge amounts of mass required. I think we told you as much as billions per day. But for instance, on the surgical masks, that China has geared up from about 20 million per day at the beginning of the year to over 200 million right now. So that's a huge number. In terms of destruction technology, which we have just been talking about with one destruction technology, there are things like the far UVC, and the problem would be that although the potential dangers don't seem to be great, there are some, and so the question becomes an ethical one. If you can kill the coronavirus and keep people from being sick today, but it causes some cancer 40 or 50 years from now, how do you discount that future harm? And so that's one of the discussions that's here. We talked about the robots. Here is one of the companies that does make the robots, and so that's another alternative, and it certainly can be complementary to the sanitizers. And we talked about the masks and the H2O2 system, and that's another thing that we get into with ozone is one way to do it. But then if we get down into the hydrogen peroxide, here's the BioQuell system, for instance, that is effective, and I envision that as something that could be redesigned so that there would be batch cleaning of masks. People could be, say even in a food processing plant, at night they could exchange and get a new mask, wear it for 24 hours, and then exchange it again. And there would be a facility at the plant which cleans these masks, and then they're then reused. And then back basically on what Bob was talking about before on the room air purifiers, that it's the effectiveness of this room air purifier over time that is important, and he's developing technology that would be able to rate that, and I think that will be very helpful.
Bob, I have a picture of that. If you want to try to, can you hand over the screen and let me show the picture, or you want to wait till later?
What I'd like to do is to do that complete interview with you, Bob, if I think that would be the way to do it. We're running a little bit out of time here today, but that would be great if we could have that. I'd like to see that.
Okay.
I appreciate that. Thanks. Yeah. So we're back now on our website, and this is the program that we're offering here, and there's I'll link to some more information that I wanted to pull out from that, but I'd like to take a minute to talk about the overall program. What we're doing for each of the suppliers here is a customized program, and it's a narrow program. It's $1,900 a year, and it has the market information in weekly alerts and so forth. The silo busting to help you coordinate with other suppliers who are with similar desires and benefits, and also with webinars such as this, and more specific webinars for the hospitals and the other end users as clean rooms, as well as for the suppliers themselves. And then internally, if we do think that particularly without the ability to travel and have your sales, even your internal sales meetings in person, having a resource such as this where we can talk about these opportunities with your people all over the world is advantageous. So that's what this whole program's about. Some of you already subscribed to some of you subscribed to our air filtration and purification report, in which case this whole program's only another $500 a year. And we do have similar services, and some of you may get our treatment chemicals or our IIoT and remote O&M or our clean room services. So those are the options for you here. But I did just wanted to quickly, in one last part of the session here, to just go back through the market alert, the weekly market alert, and just wanted to get down to a couple things we didn't cover already. One thing, we are getting a detailed analysis of what is going on in China, and the question on the mask will be, if they gear up to, they're already at 200 million per day, are they going to gear up to the point that there will be more production than the world needs? We went through this with selective catalyst for selective catalytic reduction. They had a crash program, and they put in enough facilities to handle the world's needs and completely change the market. I don't think, I think the opposite is going to be true here. I don't think, since the needs in China alone are going to be huge compared even to the 200 million masks per day that are being produced now, I don't think this is a problem. On the other hand, Sinopec, is an example, I think, for some of the other integrated producers here in the United States, with the resin all the way through the melt blown nonwovens and then to the masks. So they're one of the world's largest petrochemical companies, and they have 10 or 11 now mask lines using their own nonwovens, of course. And so that, the car companies and all sorts of people have jumped into this in China. In terms of the actual materials themselves, there's certainly, when you get the SMS and these other higher filtration media used in both the air filters and the masks, there's all sorts of interesting questions now, particularly on the reusable masks. Somebody like Superior makes or distributes needle punch felts as well. Would this have any impact on being reused with less degradation than the melt blown. So these are all the questions that will need to be asked. And back on this one thing, just on the cruise ship Diamond Princess, the CDC said basically that there wasn't any risk of the people in those cabins contracting the coronavirus, except 500 of them did. And so you've got people such as, so I'll go down here, James Chen of Purdue basically said, of course, there's no reason they wouldn't have contracted it through the ductwork. And I think this is the sentiment that a number of research institutions have come up with, is that this anything less than about 5 microns is going to go right on through the ductwork. How much of it actually lives, you may have to stay human, some of these other things. But I think this is a very important thing for the industry, is that there is airborne communication transmission, and this is one of the big risks that has to be avoided. And then there's all sorts of room air purifier companies, and they range from ones that have very inexpensive and pretty low performance products to people like Camphil, who have spent a lot of time in Livsdal. And then you've got, I think the whole concept, and Johnson Controls is one of them, of putting all this together with the instrumentation and with the filters. And this is a hospital in Wuhan that Johnson Controls put up in just a few weeks, and used their Tryon and Coke air filters. Paul has done a lot of work in this area for the aircraft cabins, and so that is I think well proven technology, and they have shown that they remove the viruses such as the coronavirus with their HEPA filter recirculation systems. So then I think another thing is to look at all this clean room technology, where you've got all sorts of air showers and entry technologies, sanitizing modules, and I think a lot of the clean room technology can be utilized more broadly. And then there are also another of innovative portable type systems. Here's Vanguard Healthcare, that provides a complete portable operating suite, and can be moved obviously to where the crises. New York could probably use quite a few of those right now. So that's basically the presentation for this morning. We've got a little time for questions if anybody has any questions or thoughts.
I have a question, Bob. This is Bob Burkhead.
Yeah.
This is focused to Charlie Rodriguez and Robin. Your machine, could it be adaptable to cleaning face masks? Could you mount a device and use it to clean face masks with?
I had that.
The challenge is that the machine, in order for it to turn on, requires significant pressure. But Charlie, did you, forgive me for interrupting you. You have a comment?
That's a great question, because I was talking to the director of pediatric emergency services at St. Joseph's Baycare Hospital here in Tampa, and he actually called me and asked me the same exact question, but exactly what Robin just said. Our device is set to a certain standard. You have to weigh at least 42 pounds in order to make the light and the UV go off. And the reason we do that is because there are individual doctors' offices, whether it be in pediatrics or internal medicine, that are interested in this product, or could be interested in this product. So there could be a chance that little babies might be crawling around, and We don't want this going off
Right.
when there's a 30-pound baby crawling around. I mean, I
Well,
imagine by the time they're 40
that's
pounds.
for a reason. My son is a physician, and the problem they're having right now is getting enough masks, of course. So they're asked to reuse them, and they're not cleaning them. They're
I guess
reusing them.
I guess if you rigged the device, you put a box over, you put maybe a box over it. It's not made for that. It's not made for
Yeah,
that.
we can't recommend that, and our UL certification is not based on that. People can choose to buy product and do with it what they want, but we cannot recommend that.
Well, no, you'd have to create a brand new product, I think, to do this. But I
We actually have some patents pending on some products that could help do that.
Uh-huh. Well, I can tell you that there are several of these polymers that are used to make the face mask medias won't survive very well in a UV environment anyway. I mean, so it would be a criteria that some products might not work very well with UV cleaning, but it makes sense to me to be able to clean a mask and reuse it.
Yep.
Right. I think that's a very good point. And I think what's unique about this product is the combination of the ozone and the UV. And we were showing those sanitizer modules that are available from Terra Universal, for instance. So if instead of using the simple UV, they had this more sophisticated UV ozone system, maybe that's a route. I think that regarding that, Bob, the Ecolab and BioQuell is positioned, I think, to offer that H2O2 system. The Battelle is ran these tests and said it was a effective way to do it, and and so they ran a 3-year study on it and came to the conclusion that the mask could be reused multiple times. So there is a lot of work that's been done on the H2O2.
Bob, are those commercially available machines?
The machines are available. BioQuell does a lot of this in pharmaceutical clean rooms and things, and so and I'm sure Ecolab would be. Well, in fact, I am going to be getting. They promised when I talked to them yesterday, they said they would send the new study, but they have a specific study now that's going to be applicable here. But again, this was a 3-year study that showed that this could be used effectively and that the damage to the mask was not that significant. Bob, I'll send you the copy of the link to the original study.
Okay, thank you.
Other questions? Well, thanks everybody. Appreciate your spending the time and look forward to talking to you, and hopefully we can move forward collaboratively. And we'll let you know when the next webinar is scheduled. Bye now.
Thank you.
Very good. Thank you, Bob.
Bye.
Bye-bye.